All right, this is the fourth portion of the June 21st wrongs. It starts off with a 37-year-old woman. She has had one baby in the past. And now, 6 weeks later, she has a litany of issues, um, including a 3 centimeter defect in the rectal mucosa with communication with the vagina, a partially torn anal sphincter. And so then they say, without treatment, which of those things is not going to get better? So we picked the anal sphincter being partially torn is not going to get better. But they correctly, so I just didn't really read this question super well, are saying that the rectovaginal fistula is not going to just go away on its own. At least not more likely than the extension to include the anal sphincter, or extension to include the bladder, the tear. Both of those are unlikely. The fistula is a tract that forms between the two epithelial surfaces, blah, 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 blah. Once that tract has formed, it's unlikely to extend to involve other tissue planes, such as the anal sphincter. Okay, so I guess what they're really getting at was that maybe the way that we read this wrong was that they weren't saying what was going to get better or what was going to get worse. They're saying what was going to happen with the fistula. And then the answer is just that the fistula is going to stay the way that it is, not that it's necessarily going to get worse. Here we have a patient who, what's going on here? So he's got the painful lesion. He has malodorous discharge. He has an irregular shaped mass. That's right. Okay. So he has an irregularly shaped mass extending from the skin of the hypothenar eminence to the Guillain Canal and the carpal tunnel. And they're saying that the biopsy tells you they have high-grade epithelioid sarcoma. The staging has no metastases. What are you supposed to do? So we figured it's an extremity. It has no metastases to this point. And we're unsure of what a high-grade epithelioid sarcoma is even going to be doing. So we went with radiation therapy, which is not the correct answer. They wanted to do amputation of that portion of the limb. Amputation is the treatment of choice for epithelioid sarcoma, according to them. So it's a rare soft tissue tumor, and it clinically presents as a slow-growing, firm subcutaneous nodule, in particular the distal extremities. It affects patients 20 to 40, especially those with Leiomyosarcoma mini. Okay, so due to the high likelihood of subclinical spread, aggressive surgical therapy with amputation is the recommendation. Post-op radiation may benefit patients with large tumors or those with positive surgical margins, despite aggressive management, recurrence, or metastases. Okay, so radiation, they're basically saying, is an adjuvant therapy for epithelioid sarcoma. It's not the first-line therapy for treatment of epithelioid sarcoma. Here we have a 12-month-old boy who's brought in for a well child, and he has 3 ounces of weight gain over 3 months. So we're saying from 9, 10, 11, 12 month that he only gains 3 ounces. And their fun, buzzy word that they're going to give you here is paucity of subcutaneous fat and thin hair. When they say that the patient had paucity of subcutaneous fat and thin hair, along with 3 ounce weight gain spread across 3 months, they want you to do a sweat chloride test. They're saying that this patient could very well have cystic fibrosis. Okay. So we know that Staph aureus and Pseudomonas are big culprits of pneumonia for patients like that. Didn't come up in this question. Just throw that there. Okay, so next you have a 42-year-old woman who came in because she had 2-hour episode of shortness of breath after walking for 2 blocks. And she has a irregular heartbeat. So we were saying that she's got atrial fibrillation. The ECG is telling us that she has atrial fibrillation as well as left ventricular hypertrophy. And what do they want to do for the next step? And they want to do echo. They want to do echocardiography. So we went with cardiac stress scintigraphy, thinking that she has chest pain. And so they had cardiac stress scintigraphy and ECG exercise stress test both as options. And so we just went with the cardiac stress because I guess it just seemed like it would be a good idea. But they're saying that that's a screening test for the diagnosis of cardiac ischemia from coronary artery disease. Exercise stress test is first line, but cardiac Stress scintigraphy can be used to evaluate cardiac perfusions for patients who have a contraindication to the stress test. So the patient, they're saying, doesn't have exertional chest pain. Okay, so I don't think that's super fair. I mean, how many times have we been told that you can't just go off on the typical features for cardiac ischemia? But in this particular instance, they're saying she doesn't have any chest pain, she just has shortness of breath. So in the instance of shortness of breath, what they're looking for is to do an echocardiography test. All right, so the next one is a really cool one where they say, what are you going to do to slow progression of a patient's renal insufficiency? And you're supposed to somehow know that their dose of lisinopril is insufficient. All right, the dose of lisinopril was insufficient. Instead, we chose increased dietary protein, knowing that that probably wasn't right, but it was the only thing that actually sounded like familiar. Okay. But they're saying, as I kind of felt at the time, that increasing dietary protein is going to actually make things worse. So patients with this condition, meaning chronic kidney disease, should aim for low diet in potassium and protein. So low potassium, low protein, in order to reduce glomerular filtration injury, as well as one that's low in sodium and phosphorus. So high protein diet, of course, is not the recommendation for this person. So of the options, they gave you the use of an ACE inhibitor, such as lisinopril, causes relative efferent arterial dilation, and reduces systemic hypertension. So I think that that's really what they're getting at. They just wanted something. What of these is going to decrease the hypertension in this patient? So this is a decrease exercise? Well, certainly that's not going to help. Say increase fluid intake. Well, I mean, that's almost fair, to tell you the truth. Let's see what they're saying is the reason why that's wrong. They're saying that it could either have a neutral or harmful effect in the setting of kidney disease. I don't know if that's necessarily true, but they're saying that patients who increase fluid intake in the setting of kidney disease could increase their risk for hypertension. Again, the thing that they're trying to get rid of here. So they're basically saying that the thing that can slow progression of patients' renal insufficiency is lowering the blood pressure. And in this particular instance, the only answer they gave you that could do that would be to increase the lisinopril dose. So the next one is a 47-year-old man with pulmonary hypertension. Well, they just give you that he's a Chubbs dude. I don't know. They may have mentioned plus or minus that there was some snoring going on. They even tell you that he uses CPAP. So they're not trying to hide it here. Split S2, prominent P2. He's got 2+ pretibial and ankle edema bilaterally. So just bad pulmonary hypertension. And then one of the things is going to be low in the patient. Okay, so the thing that's going to be low is anything past the lungs, blood pressure wise. So they're basically saying that the left atrium, left ventricle is going to be low pressure because it's having a hard time getting the fluid over there. So just keep that in mind. Pulmonary arterial pressure is higher. Pulmonary vascular resistance higher. Right atrial pressure higher. Central venous pressure higher. All of those are higher in somebody with a high amount of pressure in their lungs, and especially the vessels into the lungs, which is what happens in somebody with sleep apnea. Okay, so the next one is previously a 22-year-old woman. She has 3-week episodes of stabbing pain in her right lower abdomen, and each episode lasts about 2 hours. And again, they don't really hide anything here. Towards the end, after a long paragraph, they tell you, well, there's a partially cystic mass in the right ovary with a single echogenic nodule with decreased blood flow. And what are you going to do? And the options that you got between were ovarian cystectomy, sounds like a cyst, or right salpingo-oophorectomy. And I wasn't really sure how you're going to take out just the cyst, so I went with right salpingo-oophorectomy, but they really want ovarian cystectomy here. She has intermittent severe abdominal pain in the setting of a large heterogeneous cystic ovarian mass, which is probably having some intermittent ovarian torsion. Okay. So they're basically saying that the right salpingo-oophorectomy or removal of the right ovary and fallopian tube may be used to treatment of prevention of ovarian cancer or recurrent ovarian cysts. She doesn't have recurrent cysts at this point, she's just having the one. So given the ovarious contribution to appropriate hormonal balance in the premenopausal patient, surgical oophorectomy should be avoided if possible. I agree. Just didn't know that you could only pull out a cyst. But as it turns out, in this particular patient, you can just pull out this mature cystic teratoma. It's a benign tumor of ovary derived from all three of the germ cell layers. So they commonly contain mature structures such as teeth, hair, bone. Stuff that we know. Complex cystic adnexal mass with internal echoes. These masses become enlarged. They can cause ovarian torsion with ovarian ischemia and consequent necrosis. So they should be treated with ovarian cystectomy. All right, here we go. We got a 37-year-old woman, and they're saying, what's the most appropriate recommendation for her at this visit? Endometrial biopsy if she doesn't have any abnormal uterine bleeding. So it's not that. Mammography, apparently she's not old enough. It's saying that she's 37 years old, and they don't want to do that until she's 40. All right, she's got 3 years until you're doing a mammogram on her. 37-year-olds apparently don't need a mammogram. Next one was measurement of CA-125. That's nonsense. Not going to do that as a screening test. Testing for BRCA. They are getting on this because there's some cancer history in the family. Mom had breast cancer at 63. Aunt had endometrial cancer at 54. Paternal grandmother had colon cancer at 72. Those aren't really BRCA cancers, so far as I can tell. There's family positive for breast cancer, but it's not in the high risk age range because that lady was older, and there wasn't really anybody else with breast cancer. So that's not what they're looking for here. And the next one is to